When you flip a light switch at home, you expect the light to come on.
Right. You don't think about the grid, the cables, the substations, the transformers.
You care about the result. And for a long time, that's how most people treated healthcare. You get sick, go to the doctor, pay the copay, go home.
But now the light's flickering and the electric bill is outrageous.
Exactly. So today we're decoding a guarded document, the SWFT Healthcare Intelligence Briefs.
This one covers May 26th to June 2nd, 2026. And normally it's not for the public, it's for benefit consultants, investors, major employers.
The people managing the grid.
Right, and the brief's central idea is simple. The battle over affordability isn't mainly about the sticker price of a pill or a hospital bed anymore.
It's about infrastructure.
The plumbing, the dispute portals, eligibility checks, and bureaucratic rules that decide what you pay and how care actually feels.
And that matters because the pressure on regular people is getting intense. J.D. Power says commercial health plan satisfaction fell to 562 out of 1,000.
That's a bad score, and the reasons are financial. 53% of members got premium increases, which drove a 116-point drop in satisfaction. 34% got deductible hikes, with another 111-point drop.
So plans are controlling their own costs by shifting more of the burden to patients.
A blunt instrument. Make people pay more out of pocket, and maybe they use less care.
And it's not just employer coverage. In the ACA marketplace, average deductibles jumped from $2,759 to $3,786 in 1 year.
That kind of jump feeds what the brief calls an adverse selection death spiral. Healthier people look at a deductible like that and decide the premium isn't worth it. They drop coverage. The people who stay are sicker and need more care, so costs rise, premiums rise, and more healthy people leave.
And the brief says that's already happening. National ACA enrollment is down about 5%, with projections of a 17 to 26% decline.
And the squeeze hits Medicaid, too. The brief outlines upcoming CMS work requirement rules starting January 1st, 2027. Adults 19 to 64 will have to show qualifying work or community engagement.
Reuters says the standard is expected to be 80 hours a month, with states verifying compliance semi-annually or even more often.
Whatever your politics on work requirements, operationally it's rough. States get more bureaucracy, and lower-wage workers face coverage churn.
Meaning they bounce on and off Medicaid because they missed paperwork or worked 75 hours 1 month instead of 80.
Exactly. So the system keeps passing inflation around until it lands on the patient.
And with that pressure building, insurers are trying to recast themselves as the good guys.
They're arguing they're the cost negotiators for consumers, and that hospital consolidation and drug makers are the real inflation drivers. Because whoever loses that public fight gets the regulatory heat.
Which means the fight moves underground into infrastructure. A good example is the No Surprises Act and the Independent Dispute Resolution Process, the IDR.
That process was supposed to protect patients from surprise out-of-network bills by letting hospitals and insurers fight in arbitration instead.
But hospitals have been winning. The brief says providers prevail in 88% of IDR cases, with some awards 3 to 4 times higher than comparable in-network rates.
So now HHS, Labor, and Treasury have overhauled the process. CMS is capping batched items in a single dispute at $50, and the administrative fee drops from $115 to $15 per party.
And that sounds tiny until you look at the math.
Exactly. If a hospital billing clerk has a $200 unpaid out-of-network claim, a $115 arbitration fee makes the fight pointless. At $15, especially with batching, it suddenly becomes worth filing. A small technical rule changes financial leverage and ultimately where billions go.
Same thing is happening with pharmacy benefit managers, or PBMs. The brief highlights CVS suing Tennessee over a law aimed at vertically integrated PBMs.
A PBM negotiates drug prices and decides what drugs a plan covers. Historically, PBMs and pharmacies were separate, but companies like CVS own the PBM, the retail pharmacy, and the mail-order pharmacy.
And Tennessee is trying to stop that structure.
Right. The state wants to prohibit PBMs from owning or operating pharmacies there, arguing it creates an unfair monopoly. CVS says if the law stands, it could close 136 retail and specialty pharmacies in Tennessee and halt mail order service there.
So it's a market structure fight with patients stuck in the middle.
And CVS has leverage because it controls access to one of the hottest categories in medicine right now, the GLP-1 weight loss drugs.
The brief says CVS Caremark faced major backlash from patients and employers after restricting access.
Enough backlash that it reversed course. It's restoring coverage for Eli Lilly's Zepbound on commercial formularies by October 4th, 2026, and adding Lilly's oral GLP-1 Foundio.
Formulary meaning the list of drugs your plan will pay for.
Right, but CVS didn't just cave. The brief says it expects 10 to 15% savings across the GLP-1 therapy class through negotiation. And eligible commercially insured patients could see out-of-pocket costs fall to $25 a month.
Which is good for patients. But the bigger story is where the money is moving. GLP-1 use rose 140.4% from 2022 to 2024.
And at the same time, bariatric surgery fell from 217,387 cases in 2023 to 177,297 in 2024.
That's about 40,000 fewer surgeries in a year.
So obesity treatment dollars are shifting. They used to flow to hospitals, operating rooms, anesthesia, procedural care. Now more of that spend is moving toward drug makers and PBMs. The brief frames it as pharmacy spend cannibalizing procedural hospital spend.
And with traditional coverage getting more expensive, people are looking for an exit ramp.
The brief includes a viewpoint piece called Patients Are Building a New Healthcare System. The idea is that consumers are moving toward cash pay, subscription-based retail care because the old system is too expensive and too annoying to navigate.
One example is the Good Arts Companion subscription. $14.99 a month gets access to 200 free generic medications, and telehealth visits cost $19.
No deductible games, no prior authorization.
And the retail side is expanding too. The brief says Teladoc has partnered with Walmart to offer virtual urgent care, dermatology, and nutrition services through Walmart's Better Care Services platform.
You can use insurance, but the cash pay option is being pushed hard. Walmart seems to want to be a distribution platform for healthcare, not just a store with clinics.
Which sounds convenient, but there's a trade-off.
A big one. These direct-to-consumer models reduce immediate financial and administrative friction, but they fracture continuity of care.
Your primary doctor may not know what a retail app prescribed or what generics you're getting through a subscription service.
Exactly. Convenient for the moment, systemically disorganized.
The brief also says industry executives feel plenty of distress themselves.
AlixPartners data shows 75% of healthcare executives rate industry distress at 7 or higher out of 10.
Patients paying thousands out of pocket may not be eager to sympathize, but the brief says the distress comes from policy uncertainty, pricing pressure from these infrastructure fights, and labor costs.
So 95% are prioritizing strategic mergers and acquisitions, basically trying to buy better margins. And 70% are investing heavily in artificial intelligence.
Even though fewer than 30% say they're seeing clear, measurable benefit from those AI investments so far.
Right, expensive gym membership energy. Everybody feels they need it. Not many can show the gains yet.
And while that is going on, the brief flags another frontier with legal consequences: polygenic risk scores.
That's predictive genetic testing that looks across many DNA variants to estimate future risk for complex diseases, things like heart disease, diabetes, or certain cancers.
The brief says that creates a gap in employer benefits law.
Because GINA, the Genetic Information Non-Discrimination Act, protects you from being fired or denied health insurance based on genetic information. But, as the brief notes, it does not require employers to provide workplace accommodations for future genetic risk.
And the ADA protects present active disability, not a predicted one.
So if a polygenic score says you have a 75% chance of early onset Parkinson's in 10 years, you may not qualify for accommodation under the current framework, even though the forecast could be serious.
That's a legal gray zone.
A big one. The next compliance challenge may not be past claims, it may be predictive genetic risk before disease shows up at all.
So when you pull this together, the message is pretty clear. Whether you're an employer designing benefits or a patient staring at a deductible, the rules have changed.
The cost of care isn't determined only by the price on the bill. It's determined by who controls the plumbing.
The $15 arbitration portal, the state PBM law, the subscription app on your phone.
And that leads to the uncomfortable question. If more everyday care moves into retail, cash pay, less regulated channels, while predictive genetic tools become more common, who owns, controls, and protects the data that forecasts your future diseases?
Because once you step outside the traditional infrastructure, the rules change.
That's the part worth sitting with.
Thanks for joining us for this deep dive into the SWFT Healthcare Intelligence Brief.
We hope it helped you see the grid behind the light switch.
Until next time, take care.
And stay curious.